Buenas tardes a todos.
My name is Aníbal Damonte, and I'll be moderating this evening symposium. First of all, I'd like to thank MEDTRONIC that is supporting SOLACI-CACI year-round and that is sponsoring this symposium. We'll be addressing two important issues to my view, and I hope you can enjoy them. Will be as interactive as possible. So the agenda of the symposium, first of all, we're going to look at a controversial issue, which is the best strategy to address a coronary bifurcation. First, presentation, case presentation, discussion, and finally, we'll have an update on for this symposium. The speakers with us, Ricardo Costa is the president of the Brazilian Society of Hemodynamics and Interventional Cardiology. Dr. Uribe, who is an interventionist cardiologist from Medellin. Dr. Staico from Sao Paulo, Brazil. And for the discussion with us today, Dr. Coria, Daniela Coria from Santillana Hospital, and Martín Valdevenito from Chile. Let's enjoy this symposium and have a fruitful discussion. Let's begin with the first part. So first, I'll ask Dr. Carlos Uribe to discuss the DK crush is the technique of choice for coronary bifurcations. Thank you. It is an honor to be here with you. This is a very interesting issue, and I think it'll generate a lot of discussion. And this is about the DK crush, which is the strategy if stents are planned from the start. And I'd like to first ask the panelists a question. What is the criteria that you have to decide whether to go a single or a two-stent strategy? The Medina classification, which is your criteria? And these are the criteria we've been accustomed to: true bifurcation, SB lesion length less or more than 5 or 10, high risk of losing the SB, angle greater than 45 and smaller than 70 degrees. What do you think? Daniela, you may want to start. In our daily practice, we mostly also look at where that is located, the characteristics of the SB, whether it's the left main or an LDA or diagonal artery, the extension of the territory it's irrigating, and also the characteristics that are mentioned here, the access, how difficult is it to access the angle, the angulation, and the lesion greater than 10 millimeters. Any other comment? To support what was said, we do something which is quite similar. First, the location, and for that, we use the Medina score classification, and we also consider the side branch. I mean, the side branch is an important thing for the patient. The length of the lesion, the stenosis if it's over 70%, and the axis, the re-axis. And so based on this, we consider the two stent. We may start with the provisional stent, but if there are some complexity issues, then we'll see. But the side branch is really the most important. In this lesion, for example, that I'm showing you, which is Medina triple one, it's a true bifurcation. Would you begin with a two stent strategy, or would you rather begin with a provisional strategy stent? In personally, a provisional strategy, stent strategy. Any other opinion? A provisional stent strategy because of the localization of the lesion, despite its classification Medina 111. The provisional stent is a philosophy, it's a strategy. I mean, if the provisional stent fails, then another stent can be used. So provisional, and then I will just check on the result. This is what we have been traditionally, I mean, what we have learned, basically, and this is what we see in test books. Medina 111 is defined as a true bifurcation, and the strategy should be to stand. But this concept has been changing, and I'll try to prove why this has changed with the evidence. And so, um, as I said, this concept has been changing because Medina's classification, even though it's very appropriate for classification, treatment-wise is not the best. This classification does not consider the lesion characteristics, which is very important in this case. For example, length, the calcification length, the angulation. The classification is good because it's easy to name, to remember, to standardize in studies. And definitely the concept of true bifurcation shouldn't be used any longer. I mean, what is being used now, if the lesion is simple or the bifurcation is simple or complex, this is based on the following studies I'll be showing you, which is changing all of this overview to actually know when to start with the two stand strategy or one stand. I mean the provisional stand strategy. So all of the criteria. I mean the most important one is the length, and traditionally when we read the EBC consensus, and when we followed these consensus, we saw that they stated that 5 millimeters was the magical number to make the right decision. I mean, to use a two stent strategy or a provisional stent strategy. However, this number has changed over time, and this is based on this study that began to shift things by Dr. Chen in 2014. This is the definition study with criteria to define when we have, I mean, it gives us a score. So the interesting thing about definition study is that it shows that the length of over 10 millimeters is definitely the most important marker. As you can see, HR is the highest, 66 points, and then 80. This is in terms of sensitivity. As you know, this is also checked by the this other study um, by Dr. Chen, the DK crush, that showed that the length of 10 millimeters is probably the most important marker, not 5, as we had learned from the EBC. And and also the true bifurcation, which is different as in the Medina 111 classification. This is to show you, this is Professor Chan's study 2017, that DK crush shows the length 10 millimeters, which favors, as you can see, the two-stent strategy. This was also supported by or checked by Marcus and Marino's study based on the PB I registry, and that stated that the 10 millimeter length is the most important marker to define the involvement of the side branch and breast stenosis, and so 10 millimeters is the one that adapted best. However, it is important to know that bifurcation is not left main, and so I mean the difference is between um, left main and non-left main bifurcations are not the same. And this has to do with the patient safety. And as you can see in this flow chart, this is the risk of losing the side branch when a stent is implanted in the main branch. This is important to be considered. It's not so much, it is the 10 millimeters, but probably the most important criteria is the risk of losing the branch, because if the branch is lost, I mean, the main branch, then there's a risk of catastrophe, and then losing a branch could actually lead to catastrophic consequences when performing the procedure. So this is an important criteria when deciding on a two-stent strategy, as opposed to non-left main bifurcations. This If we believe that the SB, I mean, this is not as important, because if it goes to the SB, then there's more time to wait until all of the strategies are put together. And in addition to the previous one, there are strategies that actually can help us. This is Francesco Bussoda's study and Emmanuel Pan that show that pre-kissing with small balloons, I mean smaller than the marker diameter or reference diameter, so placing the stent in the MB. So this is very important. That is, if you see that there's no risk that it goes to the SB to prepare it and do what they call a pre-kissing is an alternative. So as a result, we could say that you can have Medina 111 true bifurcations, or have a true bifurcation, and that being a true stenosis or a complex stenosis. So probably we should focus on a simple or complex bifurcations because they are both triple one. But on the right, you could see that you could actually use a provisional stand strategy. And here on the right, since this is over 10 millimeters, a two stand strategy is better. Conclusions. In this first part, using two-stand strategy up front is the indication, and this is mainly based on the length. Um, True bifurcation, this term should not be used, rather simple and complex bifurcation, because it's more specific than the ostium involvement. And I will try to persuade you. I don't know if you're going to have a discussion here or shall I go on? The idea is in this, the criteria that you have set. The idea is the initial strategy and systematic strategy of a two-stand strategy. That is very clear. So would be the time to listen to the opinion of the panelists. For example, Ricardo. And so we can have probably a conclusion with the panel later on. Perfect.
After expressing his opinion, Carlos telling about using two stents as the approach, and in which cases I'd like for Ricardo to present all the arguments of a provisional stent. Ricardo, whenever you're ready. You're on mute. Can you hear me? Yes, we clearly hear you. First of all, thank you very much for the opportunity of being here with my friends, participating in this session with the interesting controversies. I have here a great friend, Dr. Staico. I learned to do bifurcations with Rodolfo, so if there is any problems, talk to him. Can you hear me? Yes, we can hear you. Loud and clear. After listening to Carlos' explanation, now we're gonna see a different perspective of the techniques that we should be using for treating bifurcation. Can you see my screen? Yes, we can see your screen, Ricardo. Sorry that you saw that t-shirt. Sometimes the controversies, we have to, we have to talk to friends and we have to see, okay, Carlos and I don't have a problem, but we do have different teams. We love different yellow teams, as we can see here. We all know that what was happened with the bifurcation and how complex it is what happens in the side branch. And what type of compromise are we talking about? Whether it's a dissection, an impaired flow, we have an important residual stenosis, or a late stenosis. If we take a look at this, the evolution of the side branch stenosis, the implantation of the stent in the SB gives us indexes that are prohibited. And with the DES, the evolution of the techniques, we see that the best results are given when we don't have an implantation of a stent in the side branch. Here, we have studies with resolute stents that show after 4 years, after 3 years, sorry, very interesting results, very good results with the primary strategy, simple strategies, with a stent implantation in 30% of the cases. This is the safety of treating ourselves in the centers here, the bifurcations with this. We should not confuse single stenting with provisional stenting. Single stenting means that it's just one stent. It's not a strategy, it's a result, it's an outcome. Here, we have a bifurcation, a true bifurcation, but not non-complex, that could work with a single stent. The great question is when to treat the side branch. What criteria should we use? And here it's pretty clear that we don't have a consensus. The angiographic context, whether there is reduced flow, occlusion risk, stenosis more than 75, 50, all those criteria have been already used in clinical trials. Any dissection, type A, B, C, the use of invasive image such as ultrasound, or in an area a bit larger than 2.4 square millimeters. The physiology, FFR more than 0.80. There are many criteria that are being used. The provisional technique considers the implantation of a stent on the side branch if necessary. And here we have a typical example. This would require a provisional technique, a stent in the left main. And here, after the implantation, a provisional technique stent, technically, which is the strategy that if you have an occlusion of the side branch, you can use a provisional. It's not it could be a culotte. But if you don't use a culotte, you can use a provisional stent or technique. The meta-analysis showed that it was not proven before the crash no benefit in favors of the more complex strategies. And the same thing happened with the myocardial infarction, more simplified provisional technique. Some trials like Nordic 1, we need to see the percentage of stenosis in the side branch is lower than 50%. So in these type of cases, there is no benefit in favor of a complex strategy. So we should use the technique to benefit, for instance, shorter periods of time, better contrast, and less use of material. We don't know the type of complexity that we have in BBC1. This is the BBC1 trial with actual bifurcations, and the results are more favorable than simple techniques. There are 2 more studies with bifurcations that are called true bifurcations. It favors the simple strategy. This is another trial, the Cactus trial, with stenosis that are more severe. We find that there is no difference between the 2 groups, but 30% of the cases in the side branch use the strategy in the more simple one. In the actual cases, 36% of the cases may receive 2-stent technique. Clearly, the provisional strategy does not apply to all cases. And here we have an example of an experience, a great lateral side branch, a diffuse main, and we have a wire. We couldn't do it with the wire, so the outcome was not favorable. When we have great anatomic variability, it's clear that complexity is similar when we think of a strategy to treat or to approach the bifurcation technique. Carlos said Medina classification, when we define the true bifurcation lesions, they don't have ways to validate completely the real complexity of the bifurcation lesion. Here we have an example, same location, proximal side branch, and we can see the extension of the lesion and the severity. There are some predictors that we need to consider: the degree of stenosis, the large plaque burden and the eccentric distribution, the significant calcification and the tortuosity, the angle, more angle, lower chances to have occlusion, but more difficult to access. When the angle is smaller, then there is more chances of occlusion, the impaired flow at baseline, and also the vessel size corresponding to myocardial territory. Some studies, some trials confirmed this information, such as COBI's 2 registry, the presence of stenosis in the left main, and the extension of occlusion. The definition criteria, as it was already discussed here, for bifurcation in the left main, criteria that are pretty extreme: more than 70, lower than 45, calcification, significant calcification, and the type of situations in which the strategy, the provisional strategy, could be not that favorable. So what is the best provisional technique that we have to consider? And the last consensus and these important trials show us that there is an important aspect that we need to consider: the need that we have to have a rewired attempt without pot, to have a complete position. Here, it's difficult to move forward, to advance with the wire. Here, another example. We had to switch technique for the side branch rewiring attempt because it's difficult to access. But if we do a pot in the right way, with the position of the distal mark right where the proper balloon should be placed, it's going to be very easy with the technique to access with the wire and to re-access the lateral, the side branch with an opened distal cell after pot. Step by step of this strategy, provisional strategy, includes SB balloon dilation, a kissing balloon, something interesting to do with a kissing balloon. And if we want to continue with a crossover strategy, we can facilitate the position within the provisional strategy. We need to optimize the expansion, kissing balloon, and this is the final result. This is the provisional strategy technique that we recommend. Same situation in more complex situations, you can offer great results. Definition 2 results showed more favorable technique results with this technique, but there are some questions whether the provisional technique was applied in the best way possible. Two aspects that we need to take into account: the predilation of the side branch. We have randomized trials that show that if we predilate the true bifurcations, we have more patency at the end of the procedure. We have this trial that tried to approach the true bifurcations, the extension of the lesion more than 5 millimeters in the side branch, the complexity And we compare this provisional technique, double stenting, guided by ultrasound, and the crossover rate was almost 20%, very similar to the randomized trials. And that makes us think that when we implant two stents, we have uh, different results in the late follow-up. The results were not different in the side branch with after 9 months, but there is a trend to have more stenosis in the late follow-up. And some predictors of a side branch restenosis, when we have a high complexity, the double stenting could be maybe the solution in this situation. So how do we evaluate a real true bifurcation lesion? Well, I would pay attention to this. We have pseudostenosis at the side branch ostium location, negative remodeling, and these studies show that as we approach the ostium in the bifurcation, it gets worse. So studies with FFR show that in a severe lesion, after treating the left main, there is a higher stenosis, 79% after, more than 35%, more than 85%. And to end, the EBC main trial, it was published and presented. It compared Resolute Onyx stents with simple stents, the single stent strategy versus dual stent strategy, two stent strategy, with a capacity of overdilation that is pretty interesting, 4.5 millimeters and 5.0 millimeters. The technique was the step-by-step layer technique. We already showed pod mandatory, and we also saw that with the provisional strategy minus stents, it means more duration. And here we have the procedural flow, 22%. It was necessary, very similar to the previous studies, previous trials. And the primary endpoint, it shows advantages for the more complex strategies in situations such as the left, the TLR, and the complexity here was included. And to end, the strongest evidence for the provisional strategy technique, when we have a small side branch, less than 2.5, a small myocardial territory at risk, a short ostial lesion, a stenosis less than 70%, an angulation less than 70 degrees, non-calcified anatomy, absence of significant proximal tortuosity, and easy to re-access. So the considerations, the final considerations, the provisional stenting is safe and supported by long-term data across different patient and lesion subsets. And it is widely accepted in the world, around the world. However, more extreme complexity is rare to see and should be avoided by this technique. Thus, it should be the default strategy whenever possible. Thank you for your attention.
Thank you, Ricardo. Thank you, Carlos. Before moving on to the two last minutes, very important to, based on these two standpoints that actually agreed a lot, I would like to hear from the panel, Dr. Daniela, Martin, Rodolfo, Staico, Juan Gaspar. So from your point of view, when we use the two-stent strategy, so the two-stent strategy, which technique or techniques would you choose in the daily practice? And the second question is, when you use a provisional stent strategy, what technique would you use when you actually, when you have the need for a second stent? Rodolfo, Martin. When I go for a two-stent strategy, my choice is always DK Crush. I feel comfortable. There are randomized trials supporting it. I feel that there's very little metal in the DK Crush. The results have been very categoric, saying that DK Crush is better than Culot. I use the Culot technique when as a bailout technique. So generally, DK Crush as a technique with a small protrusion of metal to the side branch and the main branch. So I use it. My default technique is the provisional stent strategy in complex lesions defined by definition. I usually go for the two stent strategy, and then the technique is take a crush. And when I mean, the provisional stent doesn't work, then I use take a crush, reverse TK crush, but then it's a lot of metal is left in the is left in, and if a miniculot is possible, then it kind of shared. It depends on the anatomical characteristics. So tap for the provisional stent strategy. Doctor, do you agree with this strategy, or do you have another strategy in your daily practice? I agree with Martin. I believe that we always, consider the benefit for the patient, and with this two-stent strategy is reserved for the distal main left when there is a myocardial involvement, and also as a first choice or most times is the provisional stent strategy that can actually address most of the bifurcations and the distal branch. And as Martin said at the beginning, and Dr. Costa, it's rather a philosophy. It's a philosophy rather than a technique. So, uh, so and probably concluding with a DK crush, I would leave it for specific cases. Sometimes we don't have IVUS available. So these are complex techniques that require imaging modalities for their proper optimization. And they have these stent layers, even though it's a mini crush, where we need to implant two stents to be able to resolve that bifurcation. Rodolfo is here, and I would like to listen to his opinion in terms of his strategy. It is a pleasure. My strategy is my two-stent strategy. When there's a significant side branch, just 2 millimeters or 3 millimeters from the ostium, it must be treated first, the side branch, and I use the crush technique. Mini crush, nano crush, very, very small protrusion. So you don't need to recross the wire because you do the first kissing and then the main stent. And in the provisional stent strategy, SB is the most important. 30, 40, 50% is okay, but we have to be careful so as not to worsen. It has to be perfect. So low pressure balloon to open the stent because it's a very important branch.
Recruzar e fazer o balão com baixa pressão, relação 0,9, no máximo 1:1 com baixa pressão, para não haver dissecção. Se houver dissecção, a técnica mais fácil é o TAP, mas dependendo da angulação, se for 45 graus, se for 90, ótimo, 70, ok, mas se for muito fechado, às vezes não vai conseguir fazer o TAP, vai ficar muito protruído para o ramo principal. Aí talvez tenha que puxar mais para trás e fazer um culote, recruzando o mais distal possível para deixar menos metal na carina. É isso. Obrigado.
Muchas gracias por estos comentarios.
Thank you for these comments and contributions. I believe that this sets the need. These strategies are not the same in Europe, where they probably, as Ricardo showed, in the IBC main, with a collode in most of the cases where they need to perform the crossover. The strategies in China will be DK crush, and we need to identify in Latin America. That's why I would like to, before I give the floor to Carlos and Ricardo, so as to summarize their presentations. Ricardo and Carlos are part of the executive LATAM BIF association, and that is partnered with SOLACI, and they're developing registries. So everyone who is in Latin America, I urge you to participate, so we will have our own bifurcation management. Before moving on to the next talk, Carlos, Ricardo, could you please summarize?
Ya me oyen bien, ¿cierto? ¿Me oyen
Sí,
bien?
Carlos. Perfecto.
Yo tenía una presentación montada, toda la evidencia de esto, pero creo que no hay tiempo, entonces voy a tratar de hacerles un resumen de por qué DK Crush, y yo creo...
Try to summarize why DK Crush and the two strategies. It's not to actually, say which one is the best. We would rather, supplement them. If so it would all depend on the patient, probably a provisional stent, and then try to, if collode. So I would have liked, I was quite disappointed by the IBC main. I don't know what Dr. Costa thinks about it, but I was quite disappointed because I expected to have more patients with DK Crush, but DK Crush use was really, really small percentage, and I would have liked to see, and this is my concern as an interventionist, what to do with complex lesion, provisional, and then a tap or collode compare with a DK Crush. I would have liked to, that we we're able to define which of these two strategies would have been the better. I mean, in patients with complex bifurcations. So the final remarks is that we definitely need to use to really fight for it when it's necessary, and then when it would all depend on the situation. So we'll use the right tool for the right thing. So DK crush is not good for simple lesions. So I think that each tool should be for each right purpose or each right scenario. Thank you for your summary, Carlos. I'll give the floor to Ricardo. With slides or without slides, also summarizes the strategies of provisional stent strategy. I think you have to remove your presentation. I'd like to show a case very quickly that shows the complexity and the strategy step by step. As regards EBC, the main difference, I don't think they're different. As we discussed with Dr. Chen this morning, I think that the degree of complexity is different, that in the real world, the use, two-stent strategy has to do with complexity, particularly. This case is a STEMI that we saw some time ago, trifurcation over here. We can see the patient had a cardiogenic shock. There is thrombus here. The intermediate branch is not that important, so we cross the wire in the three branches. There is the patient stabilized. Then we implanted a stent, a provisional stent in the LAD. And then there was an ostium involvement of the two branches. First, we wanted to optimize the main vessel and the distal vessel with a larger balloon, larger than the one used in the LAD. And this is the final result in the LAD. The circumflex involvement and the intermediate branch ostium involvement. You see that there's an improvement. We're using 6 French here. And then we recrossed, and we did the first, the kissing balloon, and a second kissing in the LAD. And this is the final result, favorable with a provisional strategy, single stent in a very complex anatomy, but we don't have all the criteria set by definition, such as the lesion extension and so on. Anyway, a complex case, and over here you can see a preserved ventricular function. Aníbal, just to summarize, this strategy can be very well used in a high complexity scenario in a very satisfactory, with satisfactory results. Thank you, Ricardo. I think the case was a conclusion standing up for single stent. Thank you for these contributions. We could talk about this topic for 2 days. I'm sure Latambi will organize in the future.
En todo caso, luego de la presentación de
The presentation, but I would like to stick to the times so we can leave it for the end. Let's move on to the next topic, which is very challenging and controversial because many years ago, everybody felt very enthusiastic, but then there were some data and people, lost enthusiasm. How are we doing in terms of how can we identify the patients that can actually benefit from this treatment? Rodolfo, welcome back. We're eager to listen to you.
Uma vez, estão vendo minha tela?
Muy bien.
Ok. Agradeço inicialmente a todo o time da MEDTRONIC.
We apologize, the speaker is speaking Portuguese. There is no interpretation into English, from Portuguese into English.
Estão com esse desafio, né, de demonstrar que essa terapia ela é válida, né? Quando bem feita, quando o paciente bem selecionado, ela tem bons resultados. Muito bem. A redução da pressão arterial por meio da denervação renal tem sido demonstrado em vários estudos randomizados, controlados com procedimentos simulados, como exemplos o Spiral of Med piloto, Spiral of Med pivotal, o Spiral on Med e também o radiância solo, que usa, ao invés da radiofrequência, ondas de ultrassom para promover a denervação renal. Até 2014, quando foi, todos nós sabemos, publicado o HTN3, Simplicia HTN3, a evidência era pequena, né? Poucos estudos e registros não randomizados, poucos estudos e registros controlados, até que veio um registro, né, o Simplicia, um estudo clínico randomizado com placebo, com procedimento simulado, que foi negativo no desfecho de eficiência, de eficácia. O desfecho de segurança foi alcançado, mas de eficiência não, e por muito pouco. Lembrando, senhores, que a meta objetiva era reduzir 2 milímetros de mercúrio na mapa e atingiu 1,96. Então, foi muito próximo. E hoje eu vejo isso até do lado positivo. Tem que tentar ver o lado positivo desse resultado negativo e muito mais se conhece, né, sobre denervação renal, sobre a anatomia das artérias renais, então ganhamos muito nesse quesito. E hoje os resultados são diferentes, principalmente porque os pacientes são melhor selecionados e o procedimento é melhor realizado. Há várias críticas em relação ao Simplicia HTN3, mas principalmente essas duas, né? A seleção de pacientes não foi adequada e o procedimento não foi bem feito. Não foi feita ablação nos 4 quadrantes de ambos as artérias renais e foram feitos poucos pontos de ablação. Então, aprendemos a fazer, hoje fazemos diferentemente do que foi feito na HTN3, que sabíamos que as artérias, temos que fazer ablação também nos ramos secundários, desde que eles tenham um calibre adequado, porque os nervos renais estão mais próximos da luz do vaso, nesses segmentos mais distais, e mais suscetíveis à ação da radiofrequência. Por outro lado, a seleção de paciente ainda é indicada para pacientes, né, hipertensão resistente, mas será que isso é suficiente? Não. Os refratários, tomando 5 ou mais classes de medicamentos, também não, porque alguns pacientes, mesmo refratários à terapia antihipertensiva clássica, eles não são bons respondedores o procedimento de denervação renal. Portanto, devido a essa variabilidade na resposta à denervação renal, um preditor prático, não invasivo e pré-procedimento se faz necessário para tentar identificar aqueles candidatos ótimos para a terapia de denervação renal. Sabemos que o sistema renina-angiotensina-aldosterona exerce um papel fundamental na regulação da pressão arterial e também é alvo de vários medicamentos antihipertensivos. Lembrando aos senhores que os rins, eles são fontes de estímulos simpáticos que atingem o cérebro pelas vias aferentes, de núcleos hipotalâmicos atingem os diversos órgãos, causando vasoconstrição, aumento da frequência e contratilidade cardíacas, redução do fluxo renal, redução do ritmo de filtração glomerular, aumento da renina e retenção de sódio e água. A renina, ela é mensurável e, em certos modelos animais, ela se reduz significativamente após a denervação renal, assim como a norepinefrina tecidual. Vemos aqui, nesse trabalho pré-clínico, nesse estudo pré-clínico, a redução significativa dos níveis de norepinefrina renal, principalmente quando a ablação é feita no ramo principal e nos ramos secundários, com redução de 92% da norepinefrina, representado aqui nesse gráfico pela terceira coluna, redução mais significativa da norepinefrina. Aqui a quarta coluna é quando foi feita 2 ciclos de ablação na artéria principal, que não reduziu mais a norepinefrina. Então, hoje o que fazemos é a aplicação de radiofrequência no ramo principal e nos ramos secundários, aquém do parâmetro renal, e desde que eles tenham 3 ou mais milímetros de diâmetro. Porém, os efeitos da denervação renal no sistema renina-angiotensina-aldosterona humano, em particular a atividade da renina plasmática, ela é enganosa, porque os pacientes estão em uso de medicamentos que alteram os níveis de renina e de aldosterona e confundem os resultados. Primeira questão, então, como é possível avaliar essas mudanças da atividade da renina plasmática e aldosterona após a denervação renal? Isso é possível? Teria que tirar todos os medicamentos, né? Dosar, então, a aldosterona e a renina sem medicamentos. Isso é feito também já é feito de rotina para descartar a hipertensão secundária. Então, são exames que são feitos de rotina para se indicar o procedimento, né? Mas o paciente teria que não estar usando medicamentos que interfiram nessa mensuração. E nós temos, lembrando, senhores, o spiral of med, ou seja, pacientes sem medicamentos ou usando poucos medicamentos, 1, 2, 3, que pudessem retirar esses medicamentos, que mantivessem a pressão entre 150 e 180 milímetros de mercúrio, foram submetidos, incluídos no estudo, e submetidos ao procedimento de denervação ou ao grupo procedimento simulado. Segunda questão, a atividade renina plasmática basal prediz a resposta à denervação renal? Para responder essa pergunta, eu trago, senhores, essa publicação recente, do dia 15 de junho agora, né, do Félix Mafu, um grande entusiasta e conhecedor profundo do tema. Foram 331 pacientes do Spiral of Med, né? Vejam, 166 para o grupo de denervação. Vejam, senhores, que 40 pacientes foram excluídos, quase um quarto, né? Quase 25%, porque foram detectados medicamentos antihipertensivos na inicial ou aos 3 meses. Né? Mesmo falando que não podia tomar medicamento, os pacientes tomam. E, às vezes, quando é para tomar, não tomam. Isso também foi um fator bem confundidor no HTN3. Até 40% dos pacientes tiveram mudança na prescrição durante o segmento. Isso também pode ter confundido os resultados. Aqui, divididos em 2 grupos, aqueles com atividade renoplasmática abaixo de 0,65 e aqueles maior ou igual a 0,65. A pressão mensurada em consultório, 2 semanas, e aos 3 meses, mapa e pressão de consultório. Aqueles pacientes com atividade renal plasmática acima de 0,65 nanogramas por mililitro por hora eram mais jovens, tinham frequência cardíaca mais elevada, isso também é fácil de entender, se eles estão sem uso de medicamento, não usam beta-bloqueador, têm atividade simpática elevada, frequência cardíaca aumentada. Por outro lado, os níveis tensionais, é importante salientar aqui, que foram semelhantes, né, entre os dois grupos. Isso também é bastante importante, porque sabemos que aqueles pacientes com níveis tensionais mais elevados respondem melhor ao procedimento de denervação renal. As mudanças da pressão da mapa em 24 horas nos pacientes com atividade renina plasmática acima de 0,65, a redução foi significativa, o que não aconteceu com aqueles pacientes com atividade renina plasmática menor que 0,65. Tanto a pressão sistólica, quanto aqui à direita, a pressão diastólica. A pressão diastólica em pacientes com atividade renina plasmática menor que 0,65, sem significância, aqueles com atividade renina plasmática mais elevada, redução significativa. Em relação aos quartis, analisamos os quartis, 4 quartis, né? Aqui o terceiro e quarto que responderam melhor, ou seja, aqueles com atividade renina plasmática maior que 0,67, tanto para mapa quanto para pressão de consultório sistólica, né? Os quartis com níveis abaixo de 0,67 não responderam ao procedimento de denervação renal. Vejam aqui, na coluna de baixo são os controles, né? Independente se é controle, não fez procedimento de denervação. Então, em azul, a pressão basal, em vermelho, 3 meses de segmento, sem alteração, tanto para níveis de renina baixos, com níveis de renina mais elevados, e já nos procedimentos aqui acima de denervação renal, aqueles com renina mais baixa, sem resposta adequada, e aqui, aos 3 meses de segmento, a linha vermelha, mostrando uma redução significativa da pressão em todas as horas, praticamente, aqueles pacientes com atividade renina plasmática acima de 0,65. Assim como a renina, a atividade renina plasmática reduziu também os níveis de aldosterona, significativamente naqueles pacientes submetidos à denervação renal. E essas mudanças foram observadas já com duas semanas de segmento. Vejam aqui aos senhores, com 2 semanas de segmento. Renina baixa, sem significância. Renina mais elevada, acima de 0,65, redução significativa da pressão sistólica em consultório, já às 2 semanas, que manteve o resultado aos 3 meses de segmento. A mesma coisa em relação à pressão diastólica, aqui no gráfico abaixo. Com 2 semanas, já uma redução significativa dos níveis tensionais, mantidos aos 3 meses de segmento. Essa observação precoce da redução em 2 semanas não me trouxe surpresa quando eu li esse artigo, porque no cenário de denervação renal para hipertensão, a gente já vivencia isso. Os pacientes, após o procedimento, devem ir para a unidade de terapia intensiva, ficar sob observação restrita, porque a pressão, no mesmo dia, já é uma queda acentuada. Esses pacientes não podem ficar com pressão muito baixa, porque estão acostumados com o regime pressórico mais elevado. 150, 180, 200, às vezes 220. Se você abaixa para 100 milímetros de mercúrio, vai fazer hipoperfusão renal, vai fazer insuficiência renal, né? Pode fazer até isquemia cerebral. E esses pacientes têm, não infrequentemente, já tive 2 casos que precisaram ligar droga vasoativa durante 1 ou 2 dias para manter níveis pressóricos em 130, 140 milímetros de mercúrio, que é adequado nessa situação, nesses primeiros dias, até o organismo se readaptar. Em cenário da denervação renal para arritmia ventricular refratária, já em 2012, essa publicação de Oquina mostrou que com 2 semanas já uma redução significativa da taquicardia ventricular e também, já na primeira semana, nenhuma ausência de fibrilações ventriculares. Então, a gente vê que não precisa esperar tanto para ter uma resposta do procedimento de denervação renal. Observamos também aqui nessa nossa publicação, nesse caso, após já o primeiro dia de denervação, uma redução significativa das taquicardias ventriculares, das terapias antitaquicardíacas ou dos choques, né? E que se manteve ao longo do tempo. E todos os outros 9 pacientes também, são 10 nessa série publicada em 2015, todos, né, a publicação mostra aqui com 1 mês, mas já no primeiro dia há uma redução intensa das arritmias cardíacas. Então, a resposta é bem imediata mesmo. Arritmias, terapias antitaquicardíacas e também dos choques. Resumindo esse trabalho do Félix Mafu, então eu diria aos senhores que pacientes com hipertensos resistentes, né, sem uso de medicamentos, né, foram submetidos à denervação renal por meio do cateter spiral da MEDTRONIC, desconectando, né, o cérebro dos rins. Dosagem de aldosterona e atividade renal plasmática pré-procedimento e no segmento aos 3 meses. Vejam aqui, aos senhores, uma redução significativa dos níveis plasmáticos da atividade de renina e da aldosterona. E também os níveis pressóricos, eles reduziram apenas naqueles pacientes com atividade de renina plasmática basal acima de 0,65. Aqueles pacientes com atividade de renina plasmática menor que 0,65, não houve diferença na redução dos níveis pressóricos. Gracias.
Muchas gracias, Rodolfo.
Thank you. Very clear presentation and an update of the current status of the state of the art in terms of renal devastation. And I'd like to take to use the last minutes of this symposium to ask Dr. Daniela Coria and Dr. Martin Valdevenito, what is the current situation in your centers in terms of, are you receiving patients for renal denervation? Are you doing renal denervation? And these variables that allow identifying patients that will benefit the most, as Rodolfo showed, do you think they will make they will improve the practice? Yeah, the truth is that in Chile it's a little difficult because we have problems with the reimbursement for renal denervation, but we're working on it. We are now trying to develop renal denervation programs, and the social securities, the healthcare system is paying attention to it. We're fighting politically because we need to consider the professional fees. So, but we have reimbursement problems, as I said. I think that's going to happen. It's going to pass too, and we're all pushing towards getting that. I think that will change with the new evidence that is coming out. So we're creating new programs, and I hope that in the next months or years we have more volume and people is more interested in this technique. Doctora Coria? No, we don't have a lot of patients that required renal denervation. At the beginning, yes, but now the number has gone down, and the same clinical cardiologists are not referring them. It's not that it's being rejected due to a financial issue. It's just that the clinical cardiologists are not sending these type of patients, are not referring them to us for these cases. Juan, since you're here in this webinar supporting us, how do you see that from the point of view of facilitation, facilitating access to renal denervation? Thank you, Aníbal. I am the director of the medical. I don't have a disclaimer, but I do say that I think the Rodolfo's presentation is the possible key to this, to be able to discriminate which patients get benefits and which ones do not benefit so much, and when do we start having that benefit is the main indicator. As Dr. Coria said, they don't send patients because they are in that gray area where they don't know when they will have the results, what happens with the denervation. And those results that he showed, I think, are the key to open that therapy. And I think that the private payers around the world will start to accept the treatment, perhaps for the most complex patients at the beginning, maybe not so much later, but I think in November we will free that data. It's a key study for the United States, and that data will be published, and then ongoing papers will be published so that the procedure starts being indicated in general in Latin America and around the world. Thank you, Juan, for your comments. We are 15 minutes past the time for this symposium. As I said before, we could have maybe a specific bifurcation activity and another one to develop the program of renal denervation, but now we have to close because the scientific committee has allocated to each one of these activities. So for me as a moderator, it was very enriching to listen to all of you. I want to thank the speakers. I want to thank the interaction of the panelists. And once again, we have to respect the times. That's the reason why we want to still continue. We still want to continue discussing and asking questions. I'd like to also thank to all the attendees in great parts of Latin America. It's almost 9 o'clock. It's very late, and I know that there is a huge number of colleagues that are enjoying this symposium. So I want to thank you all, and we'll see each other tomorrow in the 4th day of the SOLACI-CACI 2021 Congress. Thanks, everybody, and good night.
Gracias. Buenas noches.
Buenas noches. Thank you.
Gracias. Gracias a todos.